بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين. Thank you, Magdalene, for this informative presentation. Greetings all and welcome to the second part of the multimodality approach to managing locally advanced breast cancer, the recent advanced technology. Here we have a couple of goals that we will try to cover by the end of the presentation. The first, what is locally advanced breast cancer and what are the stages of locally advanced breast cancer, already discussed by Dr. Magdalene, but I'll try to go quickly just to emphasize what she had said. Breast cancer stands out as the most frequent, a leading cause of mortality in Sudan and globally. Locally advanced breast cancer, along with metastatic disease, constitute for more than 2/3 of the initial presentation in Sudan. And as Magdalene said, locally advanced breast cancer is a heterogeneous collection of breast cancer, but has no universally agreed definition. However, one consensus describes it as an invasive breast cancer that has progressed locally without distant metastases, and which include involvement of the chest and skin, or both inflammatory cancer and cancer that involve multiple local lymph nodes. But there is controversy regarding the breast cancer larger than 5 centimeters. Also, it can be defined according to TNM staging and usually include clinical stage T4 and nodal stage 2 or 3 with any T stage. But again, here, the disagreement appears with T3 when present with N0 and with N1. Another definition is a biologically aggressive breast cancer, including inflammatory carcinoma, as well as the rapidly progressing phenotypes. These are the 4 categories of the AJCC staging system, and the clinical staging is based on clinical examinations, diagnostic imaging, core biopsy before treatment, while pathological staging is based on surgical specimen, including sentinel lymph node biopsy, and the post-therapy staging is applied to the patients who have been treated with neoadjuvant therapy, including chemo, radio, and hormonal therapy. And the restaging is applied to the patient in events of tumor recurrence. The quantitative categories of TNM staging include tumor, node, and metastasis, and with complete consensus, metastasis is excluded, and T4 and N2 and N3 are included in the definition of locally advanced breast cancer. However, T3 is still is an area where multiple opinions or different opinions are present. The TNM staging combined to determine the overall anatomic stage of breast cancer, grading from 0 to 4. And the total agreement is stage 3, define the locally advanced breast cancer with or without T3 and N1. Some clinicians also include stage 2B. What is stage 4 breast cancer? Excuse me, I want to hide this, cover some of my screen. Where I hide it. Yes, What is T4? T4 is any tumor size extent to the adjacent structures. When chest wall involved is T4A. Only skin involved is T4B. And when both skin and chest wall involved is T4C. And the T4D is the inflammatory carcinoma. This is illustrations of AGCC clinical nodal staging classification demonstrate the N2 and N3 that included in locally advanced breast cancer. And with the evolution of sentinel lymph node biopsy and targeted axillary dissection, accurate initial lymph node staging is crucial for the effective treatment of breast cancer. And the new adjuvant chemotherapy can downstage lymph node to a negative status. So it can result in a favorable outcome and therefore requires placement of a biopsy clip in biopsy-proven metastatic axillary nodes. Going to inside of stage 3 and its subgroup. Looking for presence of N3 in stage 3C and T4 in stage 3B, which are typical of locally advanced breast cancer. That means these with consensus are locally advanced breast cancer. However, still contention is in stage 3A, where T3 might be associated with N0. Okay, the second objective of this lecture is how are locally advanced breast cancer diagnosed, stage, and re-stage. As you know, breast cancer, early or advanced, is diagnosed and staged with triple assessment. Clinical and pathological assessment is going to be discussed later in the symposium. And the conventional breast imaging has been already discussed by my colleague, Dr. Majdulin. So I'm going to discuss the advanced breast imaging, including MRI. MRI is excellent technique for evaluation of chest wall, as you have seen in this image, representing T4A. In this case, this is our patient, a 50-year-old lady presented with invasive ductal carcinoma in her right breast, who underwent a pre-treatment breast MRI staging. And so obviously, the breast MRI demonstrates a multiple cancers in her right breast, involvement of the nipple and skin, involvement of nipple areolar complex, and presence of a thrombus in the internal mammary vein, as you have seen here with this yellow arrow. However, all these do not affect the stage of the disease, but we have to report it in our report. We have to put it in our report as they have impact on the treatment selections regarding type of surgery, as well as to determine if they need neoadjuvant chemotherapy or not. But MRI also help in staging of this case by determining the involvement of the skin. And if you have seen here, the large tumor have tumor band extend into the adjacent skin with remarkable skin thickening and enhancement extending for more than more than third of the breast skin. Also, the smaller lesion here demonstrate direct invasion with skin thickening and enhancement. So MRI findings denote a clinical stage 4B, a locally advanced breast cancer. Here, these are 3 examples of our patients also presenting with a T4C, with both involvement of chest wall and skin, which is so aggressive and extensive, involving the left breast and extending across the midline into the contralateral breast. This is our patient presented with metastatic axillary lymph node and occult conventional imaging cancer that could be appreciated on MRI, but not only detected the occult cancer, it can also demonstrate and stage this case as N2A. It demonstrates the axillary lymph nodes that are bulky, matted with breaking capsule, invading the adjacent, not only the pectoralis muscle, but also the chest wall muscle, as you have seen here in the subtracted image. MRI not only demonstrate the pathological node, but can also show the normal lymph node basins in the evaluation of breast cancer patients. This our patient was a lactating woman presenting with 1 year progressively increasing mass, seen here on mammography. MRI not only further characterize the primary cancer, but also evaluate the bulky and extensive axillary lymph node, as you have seen, and further detecting internal mammary metastatic lymphadenopathy beside a tumor thrombus in the internal mammary node. Internal mammary vein. And in this situation, diffusion weighted images is really helpful. Also, this is our patients in lesions and focal enlargement with filling defect in the ipsilateral internal mammary vein. But in the diffusion, demonstrate not only restriction of the primary tumor, but also within the filling defect or the tumor thrombus in the vein. This is also our patient, a 38-year-old woman lactating, presenting with BD orange and rapid onset left breast hardening, suspected that peripheral mastitis. Her conventional images were suspicious and underwent breast MRI that determined further disease extent. And here it is obviously the left breast enlarged and rigid, not pendulous like the right one, but not only that, it is edematous, and the cancer in the upper outer quadrant. And I remember that it was invasive lobular carcinoma. The question with skin involvement, okay? Remarkable skin involvement. The question, is it an inflammatory carcinoma or it is T4B, skin invasion? Sometimes this area is really challenging to differentiate between the two, even on MRI or clinical or whatever, and we need to go for the punch biopsy. If we think here, if we look for this direct extension of enhancing lymphatic vessels from the tumor into the subareolar plexus and into the areolar skin with irregular enhancing nodules within the skin, we'll go for T4B. But if we look for this area here, this is far away from the side of the tumor in the medial breast and demonstrate even more intense enhancement. And not only that, can you see the big vessels, lymphatic vessels, and more appreciable in the stair here, the subdermal lymphatic plexus on the medial aspect of the breast and the extension across the midline, the new phenomena of Sudanese lady. This is from the literature, demonstrate how MRI is superior to mammography in delineating the primary breast lesions in inflammatory carcinoma, which is seen in up to 98% compared to 65% seen on mammography. Again, this is our patient. Okay, stair sequence demonstrates significant enlarged left breast with remarkable parenchymal and skin edema involving the pectoralis and chest wall and extending in the breasternal region to the contralateral breast, okay, and involve the right breast. And here, this is the same patients demonstrate different multiple sequence of the same findings. Okay, interestingly, you can see here, this is irregular lymphatic vessels from this lymphedema extending toward the subareolar lymphatic in the contralateral breast. And along the course of this vessel, we can see a lesion here, which I will show you enhancing post-contrast study. And the medial skin is even thick more than the lateral side of the skin and demonstrate even restricted diffusion along with some restrictions of these scattered breasternal lesions. Here we can see the post-contrast image of the same lesions and the typical reticular or dendritic or parenchymal enhancement of inflammatory carcinoma. And here we can see in the coronal, the breasternal and the contralateral lesions enhancing, and that the lesion you have seen in the along that vessels, it demonstrates enhancement. But interestingly, look for the intense enhancement in the medial side of the breast compared to the lateral sides and even the subareolar region, okay, and the irregular satellite enhancing nodule. The typical types of lesions seen in the inflammatory carcinoma are conglomerate, small masses and non-mass enhancement. And here you can see even those breasternal lesions demonstrate enhancement. Okay, this is another patient. Our patient also, an old lady presented with residual disease seen on MRI, post positive margin resected mammary breast carcinoma in her right axilla. Can you see here the seroma cavity and the enhancing mural nodule seen within indicate recurrence, residual, sorry. Regarding this case, also our patient post-lumpectomy for invasive ductal carcinoma based on conventional images and presented with positive margins. And here we can see residual disease in her right breast that involve both the skin and underlying chest wall. And here you can see layer of the chest wall are being involved in and the MRI graded or as stage 4C. This is also our patient, a 43-year-old lady, had history of left breast invasive ductal carcinoma treated with lumpectomy, chemotherapy, and radiotherapy, presented with swollen nipple areolar complex. She has no baseline imaging, okay? And she had suspicious or borderline conventional images and underwent MRI that demonstrate a recurrence proven post-surgically. And here you can see the irregular enhancing mass at the site of scar infiltrating into the underlying chest wall muscle with the skin thickening also. She's a Sudanese lady extending toward the midline into the contralateral breast. And here you can see the maximum edema, skin edema and subcutaneous lymphatic on the medial aspect compared to the side of the lesion on the left side, on the outer side, I mean. And here there is a lesion in subareolar, explain how the clinical conditions. CAT system and the color map help in of the kinetics MRI, and the red usually indicate washout, and the mixture of enhancement reflect the breast cancer heterogeneity. And this is our patient here demonstrate more or large area of yellow, indicating plateau kinetics with this small foci of red indicate washout. And this is CAT system demonstrate the angiogenesis map, which is also important, reflecting poor prognosis and high probability of metastasis. This is MRI mapping of pathological lymph node preoperative staging, and this is here, sorry, this is enhance the axillary lymph node by the shaping coding technique. And this is very interesting technique, which is MRI lymphangiography, and nicely delineate all group of lymph nodes. These are different patients, can demonstrate different pathological or metastatic lymph nodes with different pattern of enhancement, along with, can you see here the filling defect, okay, along with lymphatics vessels. And here we can see the site of dermal injections of gadolinium. Nowadays, there is a tendency toward the use of advanced imaging to evaluate breast cancer molecular subtypes. So it can determine those aggressive type that might indicate a locally advanced breast cancer. Lesion segmentations and kinetic analysis performed on a dedicated workstation with a special software, and definitely it needs ultra-fast MRI technique. Intraoperative breast MRI. One of the recent advances is advanced technique, and it is a supine study, the same position as for operation. The perioperative supine superimposed with the diagnostic broad, as you have seen here. You can see the breast, how it's flattened in the supine, and look for the lesion, the same lesion in the bone, and here in the supine, and the same for this one. So this can help the surgeon plan the surgical incision. Not only that, but can enable the quantifications of the breast tumor deformation and displacement due to position change, which guides the surgeon intraoperatively to evaluate for residual tumor immediately after breast conservative surgery. Another goal, what other emerging breast imaging techniques are being developed for the management of locally advanced breast cancer? This is not an emerging technique, but this is, we are usually doing, or we are usually do or perform chest X-ray to evaluate for systemic stage. We can use it also for local staging. At this, we can see here our patients, and you can see the lesion extending. This is the nodule infiltrating the intercostal muscle with thickening and enhancement. And this is again another patient of ours. Look for the cancer, how it is small, but going into the chest wall. And here, not only there is lack of fat plane, but also there is thickening and enhancement, which is more specific for muscle involvement. And this is from the literature that demonstrate the difference between the CT and MRI, though the same changes of locally advanced breast cancer seen in CT, but less reliable than MRI due to lower inherent soft tissue contrast of CT. This is already discussed by Dr. Magdalene, but you can see the image here of contrast enhanced mammography, which is comparable to the MRI, okay, and can help in evaluation of disease extent. This is a local advanced breast cancer, and here can help in monitoring neoadjuvant chemotherapy, and the negative enhancement has a high negative predictive value for tumor residual or recurrence, as you have seen in this case. This is our patient. The MRI demonstrates this very small cancer. You can see it here, infiltrating also the adjacent chest wall, resulting in extensive metastatic disease, you see. And this is the corresponding PET scan, demonstrate not only the metabolic hyperactivity of the bone uptake, bone metastatic disease, but all, and the axillary metastatic lymph node, but also demonstrate metabolic uptake of the primary small lesion in the left breast. PET scan usually performed for systemic staging, but can be also used for local staging, as we have seen here. of skin involvement in inflammatory cancer, and this is non-inflammatory cancer demonstrates that satellite nodules on MRI and diffuse skin thickening and enhancement. And in both cases, there is corresponding hypermetabolic activity on PET scan. And it is usually it has a high diagnostic accuracy in detecting the lymph node, regional lymph node, that could not be seen in other imaging modality, as in these examples, level 3, and these are examples of internal mammary lymph node. Not only that, there is literature that reported the role of PET in evaluation of neoadjuvant chemotherapy. And as you can see in these two examples here, this is complete pathological response evident by complete metabolic response after neoadjuvant chemotherapy. As you can see here, this is the first one, and this is the last. And here there is a partial response demonstrate regression, and usually they depend on the in SUV max. Not only that, PET can also help in the diagnosis of recurrence, as we can see in these two examples. Post-mastectomy, we can see here just for recurrence, and this is both-wide local excision around the seroma cavity, MRI demonstrating irregular enhancing recurrent masses associated with overlying skin thickening and enhancement with corresponding hypermetabolic uptake on PET scan, both in the skin as well as in the recurrent masses 13 months after surgery. The last goal in our presentation is what advances have been made in imaging to evaluate the efficacy of neoadjuvant chemotherapy for locally advanced breast cancer. Here, this is our patient, which we have seen earlier. A 37-year-old woman had an invasive cancer, and her prognostic stage 3C, grade 3, ER/BR positive, HER2 negative. She has received neoadjuvant therapy. MRI was performed after the second cycle due to new bloody nipple discharge, but surprisingly, MRI showed almost 50% reduction in the tumor size. As you have seen here, this is the baseline image, and this is both therapy image. Not only that, but also can you see the regression of the bulky axillary lymph node as well as the internal mammary node, and almost complete regression of the tumor thrombus in the internal mammary vessels. Here in the sagittal view, you can compare how the bulky axillary lymph node regressed significantly. And both neoadjuvant chemotherapy response is usually not concentric. That can result in what is called shrinkage star sign, as you can see it in these examples of bilateral breast cancers. According to RIST guidelines, there are 4 categories of response. Complete response include disappearance of underlying cancers. A partial response if there is at least 30% regression of the disease, and the progressive response is associated with at least 20% or more increase in the disease, and the stationary or stable disease in case of none of the above conditions. And these usually on MRI depends on the size of the targeted tumor as well as of lymph node and their enhancement. And the complete radiological response is defined as the absence of residual tumor in the breast and lymph nodes after neoadjuvant therapy. And therefore, we might need to place an imaging guided clip to trace the primary cancer or the lymph node. And these are justified by the absence of pathological enhancement and the presence of benign care pattern, and can also be justified on diffusion weighted images by reducing the signal intensity and increase the ADC value, or decrease or absence of colon peak on MRI spectroscopy. Here example of a complete pathological response evident by complete radiological response. So MRI can predict the pathological complete response. The tumor, the primary tumor completely disappear, and the lymph node here, you can see it having a normal appearance. And this is a locally advanced breast cancer here, okay? And you can see the curve, the pre-therapy curve, okay? Washout become type 1 benign curve. And as we mentioned, the effect of treatment, okay, and the response is not always concentric due to the associated necrosis and fibrosis. And that is can reduce the specificity of the conventional MRI, but addition of diffusion weighted and MRS can improve the specificity and MRI in improving the prediction and monitoring of neoadjuvant chemotherapy. And as you have seen here, this is a diffusion ADC lesion, ADC image. Okay, you can see the lesion here. It was 0.7. It increased in post to 0.8 in both therapy effect. Okay, so it reflects a partial pathological response, which was proven post-surgery. And MRS is a non-invasive molecular imaging technique, identifies abnormal choline peak that indicate active malignant tumors, okay? And it can also discover biomarkers and altered metabolism in cancer cells by assessing chemical composition, so enhancing the diagnostic as well as prognostic capabilities. Okay, and it is a specialized MRI sequence that improve the specificity of MRI and can predict early response of neoadjuvant chemotherapy, post-neoadjuvant chemotherapy that can occur within the 24 hours of starting the chemotherapy. So to evaluate for that, just measure the choline concentrations as a baseline before starting the treatment, and then, or before the first dose, and then 24 hours after the first dose. And the responders usually show decreased total choline level after the 24 hours. Okay, and after the fourth dose, again, repeated, and then the responders definitely will show continue decrease in the choline levels. And this decrease in the choline levels correlate with lesion size. Note that the fat content of the breast might obscure the choline peak detection and give artifactual signal. And here we can see the choline peak at the 3.2 ppm, and here this is our reference. And this example of local advanced breast cancer started neoadjuvant chemotherapy. The baseline demonstrates 0.9 millimole, the choline peak, and post-therapy, it regressed to 0.4, indicate partial response, which was proven post-surgery. This is one of the recently emerging MRI, the perfusion technique, a functional imaging that can predict treatment response. And here we can see a spot of increased perfusion with corresponding increased amplitude here in the curve. And post-neoadjuvant chemotherapy, this is post completely disappear and the amplitude become flattened. The last and not the least, imaging advance is the vascular map analysis. Okay, this is the vascular map analysis. They used to measure the size and number of the vessels in the same ipsilateral breast and in the contralateral breast, and see the same findings in post-neoadjuvant chemotherapy. This is pre-neoadjuvant. Can you see the lesions and the increased vascularity in the right breast? And in post-neoadjuvant chemotherapy, demonstrate remarkable regression in size and number. They measure regarding the size of lesion, the length as well as the caliber. But the same finding seen in the left breast unchanged from the baseline because it is not a disease one, and this indicative of a responder case. So in summary, MRI has become standard in breast cancer imaging, providing detailed anatomic and functional data, including tumor perfusion and cellularity. It provides an accurate staging of breast cancer, which presents a global health challenge. Advances in techniques, including diffusion-weighted images and MRS, among others, enhance MRI's specificity and diagnostic capability. Early evaluation of treatment response, particularly after neoadjuvant chemotherapy, is essential. Radiologists, as part of MDT team, play a key role in ensuring timely interventions and utilizing comprehensive staging system to help integrate imaging findings with biomarker data to personalize treatment strategies and best patient outcome. And MRI not only can detect a locoregional disease and diagnose locally in advanced breast cancer, but can also demonstrate the adjacent metastatic disease, the metastatic disease into the adjacent organs like bone, lungs, and mediastinum or heart or so forth. And here, this is locally advanced cancer, but also associated with metastatic disease into the contralateral axilla, as well as into the mediastinal lymph nodes. So it is stage 4 disease. Patient with lab requires an MDT approach, and given the high risk of metastasis in labs, systemic staging is necessary, and I will leave it for Dr. Sarah to discuss it in more details. Thank you for attention and participations, and please feel free for any comments, suggestions, or questions.
Thank you very much, Rabab. Really interesting.
Thank you, Dr. Khalid.
Wisha, do you want to speak, to tell them anything?
Thank you very, very much, Dr. Rabab, for this amazing and updated lecture. I find it very valuable. Thank you very much. Dr. Khalid, you can continue.
Right. Our first session is finished, completed. We'll go for break for 10 minutes, right?
So the questions will be by the end of radiology?
At the end of the radiology, yeah, the second session.
Okay, thank you.
طيب نقول لكم وإذا الفجر جناحان يرفان عليك وإذا الحزن الذي كحل هاتيك المآقي والذي شد وثاقا لوثاقي والذي بعثرنا في كل وادي فرحة نابعة من كل قلب يا بلادي أصبح الصبح وها نحن مع النور التقينا التقى جيل البطولات بجيل التضحيات التقى كل شهيد بشهيد لم يزل يبذر في الأرض بذور الذكريات أبدا ما هنت يا سوداننا يوما علينا بالذي أصبح شمسا في يدينا وغناء عاطرا تعدو به الريح فتختال الهوينة من كل قلب يا بلادي، فرحة نابعة من كل قلب يا بلادي. شكرا لكم. Thank you very much. You have
شكرا لك
10
انت،
minutes
شكرا
break
لك انت على القصيدة يا دكتور خالد.
and
والله
we'll come back.
شكرا يا خالد، والله جات في مواعيدك، كتر خيرك.
اي
الله
والله.
يسلمكم. Thank
الله
you. Thank
يكرمك.
you very much.
الله
Thank
يكرمك
you.
يا رب.
شكرا يا خالد.
Yes.
Break will be 30 minutes إن شاء الله يا خالد. 30 minutes.
30 minutes or 10 minutes?
30 minutes for the
30
prayer.
minutes.
اوكي ثانك يو.
خلاص
تمام.
احنا حنبدا الساعة we will start at 3:30 right؟
تمام.
خرطوم
أو
خرطوم تايم يا جماعة، دايما الناس
خرطوم
بيكون
تايم،
في
لكن انا
خرطوم
شايف
تايم.
شايف هنا يا 3:30 خلاص 3:30. Thank you very much.
اوكي ثانك يو.
Thank you. See you at 3:40 إن شاء الله. 3:30 إن شاء الله.
اوكي.